Welcome and thank you for joining. My name is Orlando Patarroyo and I'm Health Educator for Community Health and Atlantic Health System. Today's webinar, Health is a Human Right, what LGBTQ plus individuals shall know, is represented by Dr. James M. Costin, physician and Atlantic Medical Group at Village Family Medicine in South Orange, New Jersey. Before we begin, we have a few announcements. This webinar is recorded. All participants unmute. Please use the Q&A button for questions or the chat for button for comments. Are you or loved or interested in smoking cessation? Atlantic Health System offers a free quit smoking program. This program includes an individual assessment, free nicotine replacement products, and 6-week group meetings to help you quit and stay smoking free. There are multiple days and times available with groups available in person or virtually. For more information about these groups and other resources or for additional days and times, please call 1-844-472-8499. And now I'm going to turn this to Dr. James Custer. Hello, doctor. You can.
Hi. I'm trying. It says you have to stop sharing for me to start.
Yes, stop to share. Okay,
Perfect.
thank you.
All right.
Okay,
thank you.
No, thank you,
very
doctor,
much.
and I'm sorry. Okay.
No need to apologize. Thank you so much for introducing me, and thank you everybody for joining today for our presentation. Are you able to see the PowerPoint? Okay, hold on. I want it to be full screen. Can you view everything all right here?
Yes, you can. We can see that.
Okay, perfect. All right. So thank you so much for joining me today. I'm very excited to present and thanks for your patience. Today I'm going to be giving a presentation called Health is a Human Right. It is focused on well-being and the LGBTQ plus community specifically. Now, our discussion is not specifically only for people part of that community. I think it's important information that everybody should know. And I cover a broad variety of topics, including cancer screening, sexual health, things that can apply to you no matter how you identify and whether you're an ally or in a community. So I hope that everybody can gain something from our discussion. I don't have access to see the chat easily, so please interrupt me at any time if you want me to clarify something or have any additional questions where we're at. Okay, I want this to be very informal if you have any concerns, thoughts. Financial disclosures, I have 0 financial disclosures at this time. So today, our learning objectives. So number 1, learn preventative health screenings that are LGBTQ plus health focused, but not exclusive, as I had said already. This includes cancer, sexual health, mental health, and substance abuse screenings. Considerations for those individuals looking to explore gender-affirming care, whether that be yourself while you're attending, or maybe you know somebody in your life. So that's part of it. And then lastly, how medical offices or realistically offices in general can build LGBTQ plus inclusive environments. So from the beginning, some basic information. And with a lot of the training, especially the SOGI training that has come out within Atlantic Health, some of this may already be reviewed, but for a long time, people were not clearly educated on this. So I still think it's important to have reminders. Number 1, gender identity. So this is an individual's innate sense of feeling male, female, neither, or some combination of both. On the other part of that is the natal, an individual's natal or birth assigned sex. This is based strictly on someone's assigned genitalia or their chromosomes at birth. So whether we're XX, XY, when somebody's having a gender reveal party, they are revealing somebody's natal sex, not necessarily that child or infant's gender identity. Gender expression is how a gender is presented to the outside world, whether that be masculine, feminine, or androgynous. It does not always correlate with sex assigned at birth or an individual's gender identity. So if I choose to paint my fingernails and to wear a dress, things that are considered typically feminine, in an expression that does not change my gender identity, as I myself identify as male. So you can essentially present however you like with your gender expression. Transgender is an umbrella term used to describe individuals with just gender diversity in general. And then gender incongruence is a term that we use when somebody's sex assigned at birth and their gender identity do not align. So from the beginning, mental health and substance abuse, very important discussion in regards to LGBTQ plus youth, especially in the political climate nowadays that we're seeing in different states. LGBTQ plus youth are more likely to start substance abuse at young ages and are 3 times more likely to abuse drugs and alcohol. Individuals are twice more likely to have a mental health diagnosis, such as anxiety, depression, and twice more likely to attempt suicide in their life. Transgender individuals have a likely suicide attempt up to 40%. And so these statistics are very alarming in the discrepancy between the general population, so to speak. And this does not come with necessarily somebody's gender identity, but rather the social constructs around them, whether they are accepted by their communities, whether they experience discrimination against an individual, whether they feel accepted by their family, their schooling, their employers. All these factors play into an individual's mental health when looking at what could potentially be causes of these issues. As a patient, what I really encourage individuals to think about when discussing with you is, could you be potentially experiencing some depression or anxiety? Depression and anxiety don't have to fit the traditional imagery we see on television and like the Prozac commercials where you're crying, you're sad, you're looking downward. There's many different symptoms of depression that people may not initially recognize even in themselves. We talk about, how is your sleep? Are you having difficulty sleeping, or are you up all night? Are you having chronic fatigue all day, exhaustion, chronic pain that can't be explained by any other diagnosis, recent life changes or stressors, just general poor rated health, or just not feeling well without any clear metabolic explanation, or just unexplained physical symptoms that there's nothing else that we can necessarily attribute to, but something is going on in the setting of all these other symptoms. When looking at how LGBTQ plus individuals report their health, it states that up to 23% of individuals say that they're in fair or poor health, and that is compared to the 14%, almost a 10% difference in the non-LGBTQ plus community. So, that is a large percentage of individuals. People are that 10% difference is a huge number, and it's very shocking. And I think that correlates back to the things that are discussed as far as acceptance within communities and general treatment outside of that, and feeling access to healthcare if they're able to feel comfortable within the medical setting. All of that plays into these factors. Moving on from mental health discussion, I like to talk about specific cancer screenings that individuals should undergo, and I start with trans male individuals. And so for people, this is if someone's natal sex is female and that individual has gender identity as male, and they potentially have undergone some sort of medical or surgical intervention. So when you're talking about breast cancer screening, if an individual does not have top surgery or mastectomy, then you're going to undergo routine breast cancer screening. So that begins at age 40 for the standard person, and you'll do annual mammography at that point. If an individual has undergone top surgery and there is some breast tissue that remains, the risk of breast cancer is significantly diminished. However, it is not zero. So we still advise yearly manual exams and subsequent follow-up as an approach to examining for potential for breast cancer, feeling for any lumps, bumps, abnormalities, and if there is potentially needing an mammogram or an ultrasound, depending on how much tissue remains behind. If an individual undergoes removal of their uterus and ovaries, then you want to understand if an individual has a cervix intact, they still require having standard pap smear guidelines. Oftentimes nowadays, though, an individual will have their cervix removed, and if that is the case, they no longer need a pap smear, and they don't have to worry about that moving forward in the future. As far as bone density, with a DEXA scan, that will still begin at age 65. For trans men, you want to still ensure that there's no change in bone density after a certain point in their life. On the flip side, you have the trans female community. So prostate cancer screening. This is something that is not removed during any feminizing surgery or gender affirming surgery. And it's important to note that being on estrogen treatment will reduce an individual's PSA level. So it may potentially mask any underlying malignancies. So it's really a risk versus benefit discussion. There's not clear data on the effect of estrogen in relation to prostate cancer, but certainly you may have a lower threshold for then further looking into an individual's abnormal PSA levels. Even though it's not largely high, you may want to monitor it a bit more closely, because knowing that that hormone treatment can cause it to appear lower than it may actually present. Breast cancer screening is a kind of a nuanced discussion for trans female, or trans women rather, and considering starting this for individuals at age 50, if the person has been on at least 5 years of estrogen therapy or more. The incidence is lower than in anal women, so a sex assigned at birth female, resulting in a higher level of false positive results for abnormality on mammography. So you want to have that discussion that these individuals may be monitored at bigger intervals, or closer intervals rather, before undergoing any sort of biopsy procedure or further intervention, because of the risk of false positive. You also want to do a DEXA scan beginning at age 65, that individual, if they've undergone orchiectomy, because testosterone has some protection from bone density over time. So if you remove that testosterone, then the rate of osteoporosis, osteopenia increases in people. Back to the breast cancer screening. So if somebody decides to start estrogen therapy at age 50 or later, essentially what you do is wait till that person has hit their 5-year mark. So if you start at age 50 and you go on estrogen therapy, you'd wait until somebody was 55 to then start breast cancer screening. And then lastly, so other screenings, anal pap smear screenings. So anal pap smear is essentially an equivalent of a cervical pap smear to the anal and rectal area. And what they mean is that you're looking for abnormal cells that could be altered due to HPV. The issue with this currently is that while we know there's benefit in high-risk individuals, and these high-risk individuals consist of HIV-positive individuals, men who have sex with men, and then individuals with a history of HPV-16, or individuals who routinely engage in anal intercourse. These individuals are at higher risk for HPV-related changes in the cells. So we don't have clear guidelines at this time. They're upcoming as far as frequency, at what age we start. So it's all based on kind of expert opinion. I usually start at age 30, and then tailor based on findings if the person is monogamous or non-monogamous, what we need to do as far as follow-up. But ideally, we're going to be looking into the future with more information coming out. What I think is really, it highlights is the lack of data and studies we have into these populations of the HIV and MSM people who are traditionally fit into that high-risk category of anal and rectal cancer. As far as immunizations, things that you should know for yourself or anybody in the community or not, is number one, tetanus. That's a very standard vaccination, Tdap. I give Tdap to every individual as opposed to just tetanus, because it covers diphtheria and pertussis. I do very rarely see pertussis, which is whooping cough, in adults. So I think that the benefit of just giving all three together is certainly there. Of course, yearly influenza, COVID-19 vaccination. Now, this is currently always changing. At present time, individuals who fall into high risk categories can get a second bivalent booster after a certain amount of time has passed. I anticipate that in the future, it probably will end up becoming something like a yearly immunization, similar to flu, although we have no official statement saying that. But just the way that we've been seeing the boosters come out and the recommendations for additional vaccination, I anticipate that that's where we may be looking for in the future. Shingles vaccine, or Shingrix, we give that at age 50, and that's 2 doses. And we give this to younger individuals if you are immunocompromised or if you've had a history of shingles before age 50. Shingles is a very painful rash that we experience if we've been exposed to chickenpox as a child. Nowadays, we immunize all children against varicella or chickenpox, but my generation and a lot of other individuals did not have that same vaccination available to them. So if you've had the chickenpox, you should discuss with your physician about getting a shingles vaccination at age 50. It's 2 doses, 90% effective at reducing your incidence of developing shingles later in life, which is a very painful rash and can cause nerve damage. Pneumonia vaccine, standardly given at age 65 across the board. But again, if you are younger, you certainly would qualify for this and benefit from it if you have something like diabetes, underlying lung disease such as asthma, or tobacco use or vaping, anything like that, that could put you at a higher risk for lung problems if you were to get an infection. Hepatitis B, this one is a bit more specific. So this is a routine part of all childhood immunizations. However, in an individual who has multiple sexual partners, especially the male have sex with male population, you should have your immunity checked for this because over time it can go down. If you work in healthcare, you have your titers routinely checked at every occupational health, starting a new job to make sure that you are still immune. But for the standard population, you're not always getting these titers checked. But because we do see a higher incidence of hepatitis B, it's something that's important to make sure that you have immunity against. HPV vaccinations. This is, I think, my biggest push as a primary care physician, because HPV, as I said, causes anal and rectal cancer in certain populations, but it causes a lot of other things. Traditionally causes cervical cancer, as we all know, causes throat cancer, penile cancer. And nowadays we have an immunization that's been available for over 15 years, and a lot of individuals who would have benefited from getting the HPV vaccination did not. And that's because for a period, the vaccination was only approved up to age 26, I believe. And then within the last few years, we've actually extended the approval up to age 45. Now, HPV vaccination does not get rid of any HPV strains that you may or may not have in your body. However, what the benefit is that if you were to come into contact with any further strains in life through sexual encounter, this would help prevent you from essentially catching any of the higher risk ones that could cause cancer changes. So if you're in a non-monogamous relationship or are not sure what the future holds, or just would like vaccination, I certainly encourage it for everybody. Now the current HPV Gardasil covers 9 strains. The initial one only covered 4. So it's a great one to get, and certainly you should ask your doctor about it. And then lastly, we have monkeypox vaccination. This was really big last year, around June of 2022, when we were seeing a monkeypox outbreak in New York City, then transferring into New Jersey, where we were finding cases. Individuals who are considered high risk are individuals who are non-monogamous, areas of close intimate contact. If you're out to bars, if people are wearing minimal clothing, where you could be skin to skin with somebody, those are the individuals I really would push to get their vaccinations against monkeypox. Thankfully, this year we haven't seen any large outbreaks, but certainly if somebody was interested in it, I would of course encourage them because the benefit is clearly there. All right, so moving on to gender affirming care. I like to talk about the process of beginning gender affirming care, or basically in layman's terms, beginning care to start a process of identifying the medical aspects of being transgender. And so this can seem daunting to a lot of individuals who are maybe exploring it for themselves, or a little bit uncertain to individuals, or just if you have no idea how somebody would go about this. And the WPATH is the World Professional Association for Transgender Health, and they come out with a series of guidelines and recommendations as far as what, as the medical community, we look at before starting hormone affirming therapy for an individual. It's not complex and not difficult. There's a few key bullet points that I want to highlight. Number one, for someone to begin care, you want to understand and have a story with the individual that their experience of gender incongruence, where their identity and birth sex do not align, that is a marked and sustained experience. So that does not mean that there has to be a specific time frame which an individual has felt this way. You don't have to say you have to identify as a female for 6 months or a year. That's not what the point of that statement is, but rather, can this individual have a discussion with you of how they felt this way, and kind of take you along a journey as to how they've come to identify it and what they've experienced as a person. And the reason is not necessarily that somebody has to prove themselves to you, but it's to rule out any potential underlying mental issues where somebody is acutely unable to give consent, or the patient is new to you and they may be actively psychotic and you have no idea because you have no experience with this person. You want to ensure that this is not just someone walking into your office on a whim saying, I would like to start this serious process for myself, and you have kind of nothing that would support this individual doing it, and you could actually cause them harm if it's not actually what this individual wants. So that's what you're looking for, the marked and sustained aspect of this. Again, you want to ensure any mental health conditions that could negatively impact the outcome of gender affirming medical treatments are assessed, and that kind of goes back to what I discussed. If somebody's actively psychotic or schizophrenic or something going on there, they cannot give consent or engage in understand the benefits and risks of their treatment, you should not start it at that point. And of course, any physical health conditions that could be negatively affected by the outcome of starting hormone-related therapy are addressed, and that's something that I'll touch on when I get into the specifics of that. The individual has to have the capacity to consent for any treatments, just like with any medical intervention whatsoever, so that is not anything special. And then lastly, you want to ensure that as an individual, you understand the risk versus benefit of potential effect on fertility in the future if you were to undergo any hormone related interventions. What would the initiation of testosterone potentially mean for long-term effect on individuals' ovaries and eggs and ability to ovulate if that's what somebody would want for themselves, as well as the effect on the testicles for sperm production. So often we talk about ways to navigate the space should somebody want to have genetic children in the future. Starting with trans men considerations, so contraindications to starting treatment for somebody. If somebody is actively pregnant or breastfeeding, you do not want to undergo any initiation of testosterone. If somebody has poorly controlled ischemic heart disease, you want to have a cardiac evaluation prior. So if someone's had a recent heart attack or has elevated hemoglobin levels or something that could be affected by using testosterone, then you want to ensure that they have at least had a thorough evaluation and that the benefits versus risks are there, and you may want to monitor that patient or that person more closely. You want to ensure that there's no active psychiatric conditions occurring that could prevent them from providing consent. You want to discuss with that individual and be aware that when on testosterone, you want to evaluate for risk of erythrocytosis. Erythrocytosis is when basically an individual has elevation in their red blood cells. If they get too high, it can make the blood thick, increase risk of stroke and other complications. So you would want to monitor that over time. You want to make sure that's very clear for an individual that being on testosterone therapy, you want to monitor for cessation of menses. And usually that happens at some point when initiating testosterone therapy. But on the flip side, at the bottom I touched on, testosterone treatment is not contraception. So if somebody is sexually active with somebody who could potentially get them pregnant, then you want to be very clear that some form of contraception should be used, because an individual can at times randomly get their menstrual cycle back if they've not undergone any surgical intervention, and then that can still potentially result in pregnancy. There's inconclusive data right now regarding use of testosterone on individuals' cardiovascular risk. And again, fertility, that is limited with the cessation of menses. And of course, fertility is completely gone with gender affirming surgery. People can undergo egg preservation if they're interested in having children prior to this. The complexities of that is that oftentimes certain insurances don't cover this service for individuals. If you are in a New Jersey Medicaid insurance, fertility preservation is not something that is a service that is currently covered at this time. So that can be cost prohibitive to some individuals. Expected outcomes, physical changes rather, on somebody who is on testosterone. Really, you want to make sure that the individual is aware of the irreversible changes, and that includes scalp hair loss, changes in voice, deepening of voice, facial and body hair growth, and enlargement of the clitoris. Those are the three things that you cannot undo once they've been changed with testosterone. Things that are reversible and variable over time are skin oiliness and texture. You'd expect it to become smoother, potentially less acne, increased acne potentially, and rougher with testosterone, increased muscle mass and strength, atrophy of the vagina, and then fat distribution. You expect to be some more of an abdominal fat distribution over time with use of testosterone. When looking at the time frame of when you could expect to see these changes after starting hormone therapy, it varies depending on what we're looking at. We usually see things start as early as, the majority of them start as early as 6 months or 3 months of treatment, and then can progress over time and can change as somebody is either increasing their dose that could cause further changes, or just the number of years they've been on it. We expect certain things to plateau, such as voice changes over about 2 years, changes in the size of the clitoris about 2 years, but things such as muscle mass, body hair growth, that can continue essentially indefinitely as long as somebody is on the treatment. So those are definitely things to be mindful of. For trans women considerations, you want to first rule out any potential contraindications. Largely that falls around estrogen-dependent cancer. So if somebody has a breast cancer that is hormone sensitive, right, you want to be very careful that if you give them estrogen, or the risk of having breast cancer, that that person needs to be monitored very closely, because that can induce cancer changes, or that benefit versus risk about what can be done to augment these, and do it safely for a person. You want to make sure that they don't have end-stage liver disease, because that affects the way estrogen is metabolized. And of course, you don't want to give it to somebody who cannot consent for treatment with estrogen therapy. You want to make sure that the individual is aware that even if they have undergone puberty at some point in their life, as a teenager or an adolescent, that the effects of experiencing a puberty as a natal male cannot change skeleton, such as the size of somebody's hands, feet, jaws, pelvis, and the voice, as well as height. These things cannot be reversed after you've gone through puberty with the addition of estrogen. It will not change it. Those things will always remain fixed. Certain physical features can be modified through surgical intervention, but those things that I've listed are largely things that you cannot change with surgery. With use of estrogen, you always talk about the risks of venous thromboembolism. That's probably the most prevalent side effect and thing that you want to be mindful of, although we have conflicting data regarding how often it truly happens. If estrogen is used within safe parameters. The parameters that you're following are those for somebody who is born you want to follow a natal female's guidelines. So between 1 to 200 is your goal for estradiol levels. So you want to just make sure you're staying within that parameter to decrease the risk of having a venous thromboembolism. And of course, risk factors like smoking can help increase those risks. So really having that discussion with your doctor is important. If somebody is undergoing a major surgery, having a discussion about stopping estrogen treatment 2 to 4 weeks prior to it will help also reduce the risk of post-operative blood clotting. And then fertility, you want to consider sperm cryopreservation, because over time, estrogen will have an effect on the testicles that can potentially have long-term outcomes. We don't have great data as far as to how long you have to be on estrogen for, or to what degree, or is it recoverable after using estrogen for a period, but we do know that it can definitely be affected by addition of hormones, and that you may want to undergo sperm cryopreservation prior to initiating treatment. Expected effects and time course of a regimen consisting of anti-androgens and estrogen therapy. So things that are irreversible are chest growth or breast development. A variable would be arousals, libido, testicular volume, sperm production, erectile dysfunction. Things that are reversible would be skin softening and decreased oiliness, thinning of body hair and terminal hair growth, decreased muscle mass, and then fat distribution more down to the hips and buttocks of a typical female pattern of adipose tissue. When looking at, again, the time frame that you expect to see these changes in an individual, really you're looking at a few main things, but I think the biggest focus a lot of the times is breast growth, and that begins as early as 3 months, but really plateaus about 3 years. And it's important that this factor is largely guided by an individual's existing adipose tissue or fat tissue. If they already have a lot of breast fat tissue prior to undergoing estrogen therapy, then they're more likely to have a larger breast development. If somebody is very lean and thin, and basically skin and muscle, they're going to have a lot less breast development, and that may have to be augmented in the future with a surgical intervention. The other things you're looking to monitor over time is the change in body hair, and really everything else can be variable depending on the individual's dose and how long they've been on it. For somebody who identifies as non-binary, you don't necessarily have to undergo any specific treatments. There's no clear rules or requirements needed to help a person's gender expression become more masculine or more feminine. As long as it's being done from a safe aspect in the medical part, somebody can go on as little or as little hormone therapy as they want. You don't have to hit goals of reaching a certain amount of breast tissue development if that's not of importance to the patient. If all that individual wants to do is have a cessation of their menstrual cycle and identify as non-binary, you don't have to put them on estrogen. Testosterone treatment. There's many other options. There's things like non-hormonal IUDs. There's continuous birth control. There's many other things that we can do to help an individual achieve their outcomes as long as it's being done safe. There's also things like chest binding to remove it's a non-surgical way of removing the appearance of breast, and then of course changing somebody's gender expression to be more in line with their gender identity through hair, clothing, and makeup changes. Moving on, so that is kind of the end of transgender care in a broad spectrum. But now I like to focus on sexual health, which I think really applies to a greater amount of people than we've really been educated from, growing up in health class in school, all the way to even the medical part of what our medical professionals are educated in often. So a lot of individuals don't feel comfortable discussing this with their clinician, but it's really important part of somebody's health. Starting with sexual health screenings. Anybody who has multiple sexual partners should have routine STI, sexually transmitted infection screening, every 3 months. And somebody who gives oral sex to an individual with a penis should have routine throat or pharyngeal STD testing. The data is less clear on somebody who gives oral sex to an anus or the vaginal opening. And that's because just the anatomy of a penis will hit the back of the pharynx and potentially transmit any infection such as gonorrhea, chlamydia that way. A lot of people don't know that through oral sex, you can get a sexually transmitted infection. That infection may not present in your urine testing as a standard thing. It has to be swabbed in the back. And if you have it in the back of your throat and then that individual gives oral sex to another person, you can then pass on gonorrhea, chlamydia, or sexually transmitted infection that way. So it's very important that if that's a behavior that you engage in or somebody, that should be part of their testing. Vaginal swab is the gold standard for STI testing. You can test via urine, but if it's uncertain, I always do a swab. And sexually transmitted infections can be transmitted via sexual toys. Anal intercourse, anyone who receives anal penetration unprotected should have routine STD testing as well. And many doctors do not know to test for these things. A lot of people will just order a urine test. And I think that's just lack of education or lack of exposure over time. So we're actively working to change this. But if you think that some of this applies to you, ask your doctor. They should be open to at least hearing you out, having a discussion about it, and addressing your concerns, even if they're uncertain. Because there's no harm to them, and it only benefits you if there is a potential risk. When talking about sexual health, I actually like this statistic to a degree, because what it shows me is that LGBTQ people report recent conversations with providers about some sexual health topics. So if you look at it in comparison, it's not lower than the standard heterosexual community. However, it is still low across the board. So things like PrEP, 18% of individuals have had a conversation with their provider about that, as opposed to 8%. So it's almost a disservice to the heterosexual non-LGBTQ community, because there are still people that would benefit from PrEP, which I'll get into. Discussion of sexually transmitted infections, 33% versus 19%. So, what it says to me is that clinicians and healthcare is aware that these things may be prominent in certain communities, but also across the board, we're not asking enough individuals. And on the flip side, the fact that it's significantly lower for non-LGBTQ plus people does not mean that these issues don't exist in those communities. Gonorrhea, chlamydia still are present across all populations. People can have multiple sexual partners and still identify as a cis male or cis female. So, those are all things that really, I think, is from the healthcare standpoint, comes back to people feeling comfortable discussing, whether it's the clinician not feeling comfortable addressing it with the patient, or the patient not feeling comfortable enough in that setting to actually articulate these things about themselves for fear of judgment or not receiving, the appropriate care. Moving on to PrEP, as I kind of briefly touched on. PrEP is a daily pre-exposure prophylaxis medication designed to reduce the risk of basically acquiring HIV through an unprotected sexual encounter over time, right? Or not over time, but really as an exposure. It is a daily medication by and large. There is a method to take it 2-1-1, which essentially that means an individual would take that medication 2 to 24 hours prior to a sexual activity, through that time of sexual activity, and then 2 days following it. I usually don't like this method for patients or individuals because I think it creates room for error. And if somebody is concerned that they've not done something correctly, that can cause a lot of anxiety in the individual that they may have been exposed or not necessarily adequately protected. PrEP does not prevent against any other sexually transmitted infections besides HIV. So it's important that you understand that gonorrhea, chlamydia, syphilis, mycoplasma, HPV, these are all things that are not protected with using Truvada, PrEP, Descovy, any of those medications, any of the terms we use to refer to them as, and that safe sex is still the best way to have sex. Who benefits from taking it? quote unquote people who are high risk in contracting HIV. So the new guidelines show that it's not just MSM people, it's sex workers. It consists of anyone who has multiple sexual partners. So if I meet an individual and they tell me they're a non-monogamous relationship, I certainly will have that discussion and encourage them to go on a medication to prevent the risk of HIV. It does not mean it is negligible for anybody outside the LGBTQ plus community. It certainly does exist. The drugs that we use are, again, like I talked on, Truvada. Truvada was the first one. So often people use Truvada and PrEP interchangeably. Truvada is the medication name. It is now a generic medication, so it's most easily accessed across the board and very affordable to all individuals in most part. Descovy is a newer version of that. And that medication is used if an individual has contraindication largely to Truvada, whether that be bone density issues or kidney problems. And then lastly, the newest one that's come out within the last year or so is called Apretude. And Apretude is actually completely different than the other two in the fact that it is an injectable medication, and that's given every 2 months into a muscle. And that one is, there's no daily pills taken, and essentially you come in, get your injection, get your testing, and then you can move on from there. And so that is a new one that I've begun to do with patients who maybe have a higher pill burden or forget to take their medication or would like to be tested for infection more frequently anyway. So that is certainly something that can be a discussion. Because it is new, it's a bit more difficult to get from insurances, but we've been able to successfully obtain it for a lot of my patients who are interested. How effective are these medications? After 7 days straight on the oral medications and using data to extrapolate even with Apretude, they're 99% effective at reducing transmission in regards to receptive anal intercourse and receptive vaginal intercourse or IV drug use after 21 days of being on the medication. Now, Descovy is something that can't be used for vaginal intercourse. It only applies to anal intercourse, but in general, these medications are very, very effective and very safe. And then also the OLE study shows that individuals who take the medication at least 4 days a week have a risk reduction of 100% of contracting HIV. So I don't lead with this statistic because I think it allows people to know you not have to take your medication as frequently, but I think it's a good thing to know that if you miss a dose, it's not the end of the world. You're not kind of without any protection in that. You can breathe easy. If you miss one thing, the data shows that even if you take it only 4 days a week, you still have a large degree of protection. And then the last part is before beginning to offer gender-affirming care for individuals who work in the healthcare community, you want to know, does your office foster an LGBTQ plus welcoming environment? This begins with simply addressing a patient using gendered pronouns, such as, don't assume somebody goes by he or somebody goes by she until you know that individual's preferred pronouns, which is something that we collect now with SOGI information. A simple way to identify or to introduce yourself is asking, my name is James, what is your preferred name? What would you like me to call you, right? And then based on that, you already have something you can address the person. And then from there, you can say, what are your preferred pronouns and what is your identity, and you can get into those more specific things. Often nowadays, we take care of these questions at intake, so an individual does not have to repeatedly disclose or announce it to a waiting room or put them in a position where they may feel uncomfortable. Does your office have gender neutral restrooms or restrooms that are gender affirming that state, use which restroom aligns with your gender identity? Because depending on your facilities, both may be possible. Are there any LGBTQ plus specific signage within your office that is a clue for people? Their eyes will go right to it and then clue in that this is a place that is safe and accepting. And largely, is your staff educated on these topics from a medical office standpoint? Not only is it important for the clinicians to know, but also your front desk, because they're the first contact. Your MOAs, they are the first people to meet and smile and greet the patients, and then your medical assistants. Everybody involved should really be aware of these topics and how to best care for individuals in the LGBTQ plus community. So that is my discussion today.
Thank you for joining us, and I want to special thank you, Doctor, for dedicating your time and expertise today. If you have any questions, you can email us.
Thank you so much for having me. I appreciate it, and I'm always happy to discuss. So have a lovely day, everyone. Thanks for joining me.
Okay, thank you.